Welcome for joining us today. Today is December 11th, 2019, and we are presenting our final UMTRC webinar for the year of 2019. My name is Becky Sanders, and presenting for us today is Courtney Stevens. Courtney's session was presented previously this year at our 2019 UMTRC annual conference, and her session was the most popular session of all of the breakouts. So we asked her to come back and give us a review again and see what kind of updates that she had to tell us now that the year is almost over. So Courtney, I'm going to go ahead and hand it off to you.
Thank you, Becky, and thank you for the opportunity to share this presentation again. It's always a great honor of ours to be able to share some of the good work that we're doing. So today, the base of my presentation is going to be similar to what I did in July with some added insights over the last couple months. And really the premise is how Henry Ford Health System has been able to drive care redesign by using this to transform care delivery with virtual care. So some of the objectives that I'm looking to cover with you today, one is looking at redesigning through the deployment of virtual care or telehealth, understanding what some of those key considerations are to obtain adoption scalability of these virtual programs within your organization, and then also recognizing the obstacles, the keys to success, and those learnings that we have learned over the last couple years. I've been with Henry Ford for 12 years, and for the last 5, I've been the Director of Virtual Care, looking to develop a strategy around the use of telehealth and telemedicine within our organization. For those of you that may not know, Henry Ford Health System resides in Southeast Michigan. We have 5 acute medical surgical hospitals and 2 behavioral health facilities, an inpatient psychiatric and an inpatient substance abuse facility as well. We have 48 medical centers strewn throughout central to southeast Michigan, and we have an employed medical group that is the hub of a lot of our clinical stakeholders and clinical care team that resides about 1,200 providers and scientists, but we also have an affiliated network of the Henry Ford Physician Network that spans outside of those employed physician group as well. We also have a lot of peripheral services with outpatient dialysis, home health care. We are a next generation ACO. We obtained that designation in 2015. So through this next generation ACO designation, we did also apply for the telehealth waiver, which I'll talk about a little bit later, which has allowed us to offer some of our telehealth services to those Medicare beneficiaries that are part of that accountable care organization or ACO. We do have an insurance arm. Health Alliance Plan, or HAP, is our insurance associated with Henry Ford Health System, but we are not a closed network. So we do also contract with the government payers, Medicare and Medicaid, as well as a lot of the commercial payers here in Michigan. And finally, we are an Epic electronic medical record. So in 2012, we started our transition from a legacy EMR to Epic, and we are currently using the, actually this is updated, we are currently using the May 2019 version of Epic. So I want to start with how telehealth and virtual care is really disruptive innovation. And if I go back to our founding father, Henry Ford, and our namesake, I looked at how has he really changed the automobile industry or created the automobile industry. And so if you look on the left-hand side, you see an Easter morning in 1900 on 5th Avenue, and the game that we play here is where is the automobile. And so you see the little red circle is the single automobile amongst a sea of horse and buggies that are going down this bustling major street in New York. Now, just 13 years later, if you look on the right hand of the screen, now you see 1913, that same New York street, and the game becomes where's the horse and buggy. And you notice that there's no red circle. They drastically changed the transportation industry in just 13 short years. And all that came about with the disruptive innovation of the Model T automobile. And so one of Henry Ford's famous quotes was, if I had to ask people what they wanted, they would have said a faster horse, which is very interesting because they didn't know an automobile was an option. They didn't know what new technology was coming down the pipeline. And this is a lot of what we are now dealing with telehealth or virtual care as well. People don't realize the benefits and the opportunities of telehealth. And by people, I mean our internal stakeholders as well as our customer base as well. So part of our role and our responsibility is to make sure that we are creating a transition to this new disruptive innovation that is value added to all of those stakeholders, but yet still maintains our quality of excellence as well. Another favorite quote I have of Henry Ford is, "Whether you think you can or you can't, you are right." And this is another mantra of telehealth, that we need to make sure that we're keeping this positive attitude and that we really are pushing forward with how we're going to redesign care. So looking at telehealth truly as a delightful disruption. You look at a lot of other consumer industries, and some of these I have listed on the top here, they've really not necessarily changed what we are consuming, but how we are consuming it. If you think about Netflix, they didn't change the fact that we watch as consumers movies, but what they've done is they've changed how we're doing it. We no longer peruse the aisles of Blockbuster looking for that VHS tape that we're going to take home, but instead we are now streaming and we are toggling on our personal devices to find that video that we're going to watch, but yet we are still sitting and watching that video wherever we want it to be at this time. And here's some other with banking and food delivery and a lot of the other industries that have really changed. So if we look at virtual care and telehealth, we are doing the same type of thing. We are not changing the fact that people are coming to us to get well. They're coming to us to get health care. But what we're doing is we're doing delightful disruption by changing how they are going to get that care delivered. And with virtual care and telehealth really being that disruptive enabler for people to be able to receive that care. And some statistics at the bottom here just show that exponential growth of virtual care and telehealth, that by 2022, it's estimated to be about 1 out of 10 visits will be done virtually, and also to be up to $3.5 billion of that healthcare industry. So what is virtual care? If we take a step back and really look at what it could be, all the way back in 1962, if anybody remembers the glorious cartoon of the Jetsons, I can remember getting up on Saturday mornings and watching these. And here you see a picture of Elroy getting a telehealth visit by his doctor. So all the way back in 1962, this futuristic cartoon, which had flying cars, a robot maid, all these crazy futuristic things, they were projecting telehealth. And so now, if we fast forward to 2019, it's actually surpassed the Jetsons. Now telehealth can be held in the palm of your hands in a device that you can put in your pocket and take anywhere that you go, but still have access to that healthcare specialist being able to deliver the care to you where, when, and how you need it most. And so really the innovation and transformation that has happened is that from a providers and administration perspective, you can now reach patients with barriers to obtaining care. Those barriers could be childcare, they could be time off of work, they could be distance from the provider to the patient, but now you're able to reach those patients by surpassing some of those previous life things that have happened that have stopped them from getting their own care. It also can help with patient compliance. Because of that ease of access now, they could be more compliant with their health care plan of care or care delivery. It can increase your access and your growth by taking down the barriers of brick and mortar, and also increase your footprint of your organization without you having to physically put roots in various locations. And then from a patient and caregiver perspective, giving them freer access to care, giving them radical convenience to get it where, when, and how they would like to get it, and also reducing that time off work, those travel barriers. And for some people, the biggest benefit can be foregoing that waiting room full of sick people that they would have to encounter when they're trying to get well themselves. So here you see Henry Ford Health System's virtual care mission. So this has actually gone through a couple evolutions over our 5 years as a department here at Henry Ford Health System. But our most recent version is to evolve innovative care delivery to enhance health and wellness through accessible technology that drives connection and collaboration, really driving where, when, and how it is needed most. And then when we work with a lot of our clinical partners, they really focus it on the 5 rights, making sure we have the right patient, the right provider at the right time, the right place, and the right intervention, and now virtual care being a very key intervention that can help make that connection. Finally, you also see in the middle of the screen an equation. So I'm actually an industrial engineer by background, so a lot of times I like to think in equations. But what I learned as we were going through the development of our department and our virtual care strategy here at Henry Ford is camera plus doctor does not equal virtual care. There are a lot of other components that go into that equation to really make sure that it is a successful intervention or operation of what we're trying to do. And so the equation that we've developed is that the technology, or the camera, or whatever comes along with it with the peripherals, has to be added to the operations, the build, which applies to our electronic medical record or any other build or schedule build that needs to be put in place, plus the engagement of the right stakeholders. All of that needs to be added in, and then we need to make sure that we are magnifying that by the experience that our consumers or patients are having, as well as the experience of our own internal stakeholders as well. That's truly the equation that brings us to virtual care. So just to give you a high-level timeline of where Henry Ford Health System has been over the last 10 years or so, we do have a remote patient monitoring department, which was in its grassroots as early as 2008 and formalized in 2010. And some of our key forward-thinking leaders at Henry Ford actually put a white paper together around telemedicine back in 2012. And also back then, our primary care division started doing some asynchronous visits in our legacy electronic medical record. And then as of 2012, we transitioned to Epic as our electronic medical record, and those asynchronous visits came along into that build. And really in 2015, we started our journey of synchronous visits. We started with clinic-to-clinic model and then have evolved to clinic-to-home, where the patient is in there using their own personal device. And we've also engaged with some peripheral devices. We have some Title Care programs that I will talk about today. And most recently, we went live with our on-demand video visit functionality as well, using Henry Ford providers to be able to offer a virtual walk-in type clinic for our patients. So looking back at some of those definitions that we talked about, so what is virtual care or telehealth or telemedicine? Here at Henry Ford, we've decided to label it virtual care to give ourselves more of a broad umbrella of the capabilities that we were going to encompass. But those capabilities still fall between these two major methods of delivery, one being our synchronous, our live interactive video, and the other being our asynchronous, that secure online messaging or secure store and forward. At the bottom of the screen, I've added some of the pros and cons for each of those methods, and this is something that we share with any of our clinical stakeholders that are looking to implement a capability within their practice to make sure that they are fully weighing the pros and cons of the choice that they are making. So you can see under the synchronous, we have the pros being the real-time, the more complex or complete view of the case, and more potential reimbursement using that. Whereas some of the cons is that it still has a scheduling impact, and there are the technical and equipment requirements associated with delivering in that manner. Whereas asynchronous allows us no scheduling restraints, it's less technically burdensome, and it can be an efficiency factor with your practice, but it does have limitations. It can be a delay in feedback, there is a limited view of the case, and there's limited reimbursement available as well. Now looking at those two capabilities in the upper left-hand corner, here you see our full wheel of virtual care capabilities. So here we've laid out our two synchronous, which are the dark blue boxes, which is our MyChart video visits, which is the clinic to home where the patient is using their own personal device, and then also our clinic-to-clinic telemedicine or video visits, where the patient is at a clinical facility but connecting to a distant provider using video. We do have capabilities in both, and I'll share with you some use cases a little bit later. From an asynchronous realm, we have a couple that fall under this. We have our e-visits, and we'll get into the details of what those look like, which are patient-initiated. We have our virtual post-ops, which is a version of that, but is triggered by a surgery or a procedure and can help with that surgical follow-up. We have e-consults, which are those provider-to-provider interprofessional consultations that, again, is done through the asynchronous store and forward. And then we have our remote patient monitoring, which has been around as early as that 2010 department and still continues to virtually monitor patients in their home on a regular basis. And I also added in here MyChart messaging, which MyChart being our patient portal through Epic, because that's still considered part of that telehealth delivery, although it may not come with reimbursement associated with it. So I'm going to go ahead and walk through these different capabilities that I just shared with you, starting with our MyChart video visits. So this is a clinic to home where the provider identifies that the patients are appropriate for a MyChart video visit, and it's being currently scheduled through our front desk to make sure that they're medically appropriate to be seen at a distance in their home. And then the patient is logging into their patient portal to connect to the video on their personal device, and the provider is logging into a special instance of Epic. And then they're able to conduct their visit. We are seeing some, Michigan is a parity law state for telehealth, so we are seeing some coverage of video visits in the patient home, but right now it's restrictive that our government payers are not covering in the home, although Medicaid might be opening this up in 2020. I think the best way to show you what a MyChart video visit looks like is to actually show you. So I have a short video that I'm going to play that is a patient talking about her experience with a MyChart video visit.
Because it's a convenience. I mean, if you're at the office and you need that 20 minutes, but you can't leave the office to get to the doctor's office, you can turn on your Wi-Fi and turn on your phone and do that visit within 20 minutes and be done and not even leave your office chair. I didn't have to worry about the snow or if it was raining and all that good stuff. I just sat at home, turned on my computer, and waited for a patient to come on and got what I needed to get done. The doctor, he offered it up, and I said, well, what the heck, let's give it a try. So that's what we did, and I've enjoyed it since. The experience with the first video visit was a little crazy, because I do have 2 children, but we all enjoyed the fact that we didn't have to leave the house for our first visit. And I said, when can we do another one of these? Because they were just it was helpful to not have to pack the kids up and get into the car. I was comfortable with my doctor, and it didn't matter. I knew she didn't care what the house looked like, so it was more important just to talk about what I needed to talk to her about. You have to download the app, the MyChart app, and once the MyChart app is up, you get a username and a password, and once that username and password is up, then you go into your MyChart, which will have your name and a lovely picture of you. And I go over to my appointments where it's scheduled at, and I go up into it, and there's a little green icon that I will click. And what I do is then I wait for it to all come up. My face will show at the bottom, and then whoever doctor you are seeing at that time will show up at the top. At least give it a try. That's what I would say. I mean, it's not too difficult to do, and it is very helpful in a lot of ways. And I think it'd be helpful to a lot of people.
So what's been great about this, and she mentioned the winter and the snow as well. So Michigan is one of the states known for their winters. And so we actually had some of our operational areas looking at inclement weather policies that they can put in place to actively try to transfer patients from in-clinic visits to video visits if they know that there might be issues with weather, potential no-shows of patients due to that, and really to help make sure that we're keeping in mind the safety of our patients as well, as they still want to get their care delivered, but it may have barriers of weather to be part of them getting to the clinic as well. So another version of our synchronous, or our video, is our clinic-to-clinic telemedicine or video visits. So with these, the patient is presenting or already at a clinical facility, so this could be inpatient, this could be emergency department, or it could be an outpatient clinic, but they're connecting to a specialist or another provider at a distant location that they might need to get care delivered. So what's nice about these visits is a lot of times we talk about the patients who are averse to technology and not wanting to work the technology themselves. So this is a great opportunity to find a more convenient location to still break some of those barriers of care down, but somebody else is actually working the technology for the patient because they're checking in at the front desk, They're getting roomed by a medical assistant like they typically would. And then that person or that telepresenter is the one connecting or working the technology to get the distant provider on the screen. So instead of waiting for the provider to come into the room, they're waiting for that telepresenter to connect them via video, and then they can still conduct their full visit. So these are scheduled in our electronic medical record. They're fully documented in the electronic medical record, but really give us an opportunity to expand our footprint of some of our specialists to some of our additional sites as well. And from a reimbursement perspective, now that the patient is at a clinical facility, we do see more payer coverage or reimbursement for those services. Another adaptation of these clinic-to-clinic visits is the use of a device-enabled video visit. So similar to the other version where it's just audio and video, we now add in a device called TytoCare, which allows us to do additional examination in real time and have that provider have real-time view and access to heart sounds, lung sounds, an otoscope, and a tongue depressor that they can be looking in their ear, nose, and throat to be able to have versions or samples of a physical examination, even though that provider may not physically be on the same site as the patient. The provider is logging into a web portal to be able to see both the video and the physical exam components or screen at the same time as they're conducting the visit. So this has been an opportunity for us to get that added examination in scenarios like home visiting physicians where community health workers are going into the patient's home, post-discharge with community paramedics going into the patient's home, or school-based health where the patients are students in schools with a nurse and connecting to a pediatrician when that added level of care is needed. Now moving on to some of our asynchronous capabilities. So the first that I mentioned was e-visits. So these are patient-initiated for non-urgent electronic visit conducted through secure messaging in our electronic medical record. So the patient is initiating this through MyChart, through their patient portal, and they're selecting a condition in which the questionnaire will be tailored to the symptoms of that condition, and then they can send that on to a provider that they have an established relationship with. Our current service level agreement turnaround time is 1 business day. And we are doing this at a flat fee currently, and it does get billed to insurance first. But if insurance doesn't pay, the patients are fully aware up front as to what the out-of-pocket fee would be if their insurance does not cover these. And typically, the time that it takes a provider to evaluate, diagnose, and treat based on these is on average about 3 to 7 minutes. So this can really add efficiency and from a patient's perspective, give radical convenience because they didn't have to schedule an additional visit, take time off work, and go to a visit to get this care. Another version of this is our virtual post-ops. As I mentioned, this is stemmed from a procedure or surgery. And then based on an order in Epic, it can fire a time delay questionnaire to that patient to really monitor their recovery from that surgery or procedure and get that key information to their care team to make sure that that patient's recovery is going well. And this is part of that global billing period, so there's not an additional fee associated with it. And from a surgeon perspective, this can free up time on their schedule because it's not an additional visit on their schedule, but they're able to do this asynchronously. And also with the e-consults, so e-consults being that provider to provider, giving us the opportunity to make sure that the right referrals are making it through to specialties by giving those requesters an opportunity to ask a quick question to make sure that they're doing the right plan of care for their patient. Finally, I mentioned remote patient monitoring. So this is managed through our Community Care Services division through our e-home care department. And we use a vendor called HRS, which is a tablet-based, and it has peripheral devices for things such as blood pressure, pulse ox, scale, and glucose monitoring, where they can put these in the patient's home, typically aligned with a home care nurse or a high-risk readmission patient, and they can have the patient collecting vitals on a regular basis, which are being monitored by a bay of 5 nurses 24/7, and any alerts outside of threshold can be notified to the patient, the home care nurse, or to the provider, depending on the protocol. So with all the capabilities that I shared with you, I wanted to give you an idea of magnitude. So last year, 2018, we did 7,532 virtual encounters. This year, through October of 2019, we have already surpassed 13,000. So we continue to grow programs, we continue to grow capabilities, and are exponentially growing year over year our various capabilities. And just this year, our video visits have exceeded our asynchronous visits from a comparison volume. We currently have 39 specialties or subspecialties that are participating in one of our capabilities or multiple of our capabilities that I shared with you, and almost 600 doctors that have been trained and set up to be able to offer some type of virtual care. Last year in 2018, we saved patients over 104,000 miles of travel by giving them either a more convenient location or not having to physically come to a location at all and being able to do their visits from home. And our providers, in some scenarios where the patient is inpatient or in an emergency department and we would have had to send a subspecialist to their location, we were able to save almost 3,000 miles of provider time by giving them a virtual option, which equates to about 12 clinic days. So that's about 12 more clinic days of access that we were able to free up with these very high demand subspecialists. And you can also see some of our remote patient monitoring and teleradiology volumes as well. Just a quick snapshot of those 39 specialties that are doing some type of virtual care. And based on the key in the bottom left-hand corner, you can see which of the capabilities they are exercising. Some of our areas like primary care and behavioral health services have really taken off in volume and capability. And we've got other areas like dermatology who are using a wide smattering of our virtual care capabilities to make sure that they are giving a lot of various options to their customer base. But you can see it kind of depends on the use case and it depends on the specialty, which of those capabilities they have opted to use. So I really wanted to focus in the next couple minutes on some of the use cases that I see that were really driving care redesign using some of these virtual capabilities. On the left column, I focused on where we were driving into the patient's home. And for those of you that are wondering why I keep using the word drive, I'm playing on Henry Ford and my Model T example where I started my presentation. So areas where we've really driven into the patient's home, using asynchronous with e-visits and our virtual post-ops, giving those patients an opportunity to stay within the comfort of their location, be that home or work, and still be able to get access to these various specialists, be it primary care, specialty, or some of their surgical follow-up. With our MyChart video visits, really being able to now be able to do video in their home as well, primary care has taken a huge leap and trained all of their over 300 providers and equipping them to be able to have this functionality. Our OB prenatal program is where our midwives have actually set up to do some of the 16 prenatal visits that new moms engage with, offering them the opportunity to do a portion of those virtually from their home, which has been great for some of our new moms, especially those that have travel barriers or childcare barriers with some of their older children as they're trying to navigate their recent pregnancy. We also have home-based cardiac rehab, where patients who have had a major cardiac event and need to have a visit with an exercise physiologist on a pretty regular basis during the week, being able to offer those from the comfort of their home or their local gym instead of having to come to one of our 4 or 5 cardiac rehab facilities. And finally, also partnering with our home dialysis for support. Using the TytoCare, I mentioned some of these earlier, we've been able to use it for our home visiting physicians in partnership with community health workers in the patient's home, or post-discharge follow-up using community paramedics with the TytoCare device that are entering the patient's home and connecting with that provider. And then, as always, that remote patient monitoring really driving into the patient's home. On the right-hand side, looking at how we're driving outside of our existing walls, we also have a lot of partnerships with external virtual consults. We have a behavioral integration with primary care program where the patient is staying within the primary care location, but getting access to a behavioral specialist with that limited resources throughout our region. So really being able to open up that access and availability. We have some of our specialty areas like urology and gastroenterology who are partnering with some of their external referral sources to offer pre-surgical consults or post-surgical follow-up with patients from their more local external clinic. And then finally, we have some chronic care centers that are really trying to create a one-stop shop for some of our geriatric patients, which could include virtual behavioral services as well as access to additional specialists from one centralized location for all of those elderly patient needs. And I've already mentioned our school-based health program, with the TytoCare device. So now I want to shift gears on kind of how we made some of these things happen. So if we look at our virtual care adoption and scalability tactics, we've really focused in and honed in on our virtual care team and governance, which I'm going to share with you what that looks like currently, our standardization of process and work plan, communication and how we communicate internally and externally about our virtual care capabilities. I'm going to share with you a workshop that we did in 2019 to really try to drive asynchronous adoption and ability, as well as CME events for our providers to understand how virtual care can help make their life easier, the use of our patient portal MyChart and a focus team to look at activation, adoption, and acceleration of the use of MyChart, which is the platform for a lot of our virtual capabilities. And then a focused strategic team in our organization that focused on digital acceleration, which of course includes virtual care, and focusing on the 3 sub-teams of primary care, what our digital front door looks like, how are patients getting to us or getting into us, and then also how we're going to have consumer accelerators that are really going to drive patients towards these virtual or digital options. So this is our governance structure for virtual care. On the left-hand side, you see my boss, which is our Chief Access Officer or VP of Ambulatory Business Operations. He also has responsibility for our contact center, our front desk operations, as well as our access technology, which includes our phones and some of our other online capability, and myself and our referring physician office. Then you see on the left-hand side our virtual care team, which I will share with you what that structure looks like on the next slide. But before I share that, I wanted to show you some of the infrastructure that we put together to really make sure that we had insights and the access to the areas we needed to break down some of our barriers. So we have a steering committee, which resides some of our senior leaders in the organization that meets monthly to help us make sure that we are prioritizing and strategizing the right virtual care pieces. Below that, I have an operational team that has the directors and VPs of some of the key areas like IT, our EMR, and some of the other areas that really help with navigation and connecting the dots as to other strategies that are going on in the organization, as well as making sure that we break down barriers of resources that we may need to be able to execute on some of our virtual care capabilities. This group meets every 2 weeks. Then we have our telemedicine project team. This is really our builders, our EMR builders, as well as the virtual care team, to make sure that we are keeping pulse on the programs that we have in flight and making sure that we're bringing them to conclusion. And then finally, our clinical stakeholders that may be specific to the programs that we are trying to implement, making sure that we have ad hoc meetings with them to make sure that they are operationalizing what we are developing. Another thing that we realized, and we see this on the far right side, is there was a group of corporate areas that we didn't touch every day, but we would frequently be interacting with, and it was very important that they knew what virtual care was, what our strategy was, and kind of where we had been and where we are going. And some of those areas included legal, government relations, marketing, planning. So what we did to decide to engage these groups is we developed a virtual care summit that we do internally on a quarterly basis, and it brings these groups together virtually to make sure that we are keeping them aware of what virtual care is and where we're going with it, so that if we ever need to engage with them, or if they have anything that comes across their desk, they are aware that Henry Ford is active in the virtual care space and they know who to come talk to. Now, specifically focusing on our virtual care department, so myself, I'm the director of virtual care, and I have 4 virtual care consultants that act as project managers that will take use cases and ideas from our clinical stakeholders all the way from a simple idea to implementation. And this includes coordinating the Epic build required, any of the equipment needs that they may have, as well as workflow development and how they're going to plug this into their operations. In addition to those 4 consultants, I have a virtual care analyst that helps us maintain our metrics and data on a monthly basis, as well as manages a lot of the equipment orders and procurement that we have as we're trying to facilitate our programs. Also, we just this year have added a virtual care instructional designer to our team, And this person focuses on our training materials and also facilitating both online and physical training for a lot of our users and stakeholders that are looking to implement virtual care. And so we've covered a lot of this, but the key veins of what this virtual care team supports is strategy and architecture, so the system strategic plan, the use case priorities, and also developing those operational models. The support and operations track, which includes that project management, keeping tabs of the regulatory and payment standards so that our clinical stakeholders or our users don't have to be bogged down with that. We're bringing it to them as subject matter experts in the organization. And then also vendor management to make sure that we are being efficient in the use of our vendors and making sure we're streamlining their operations. And then finally, from a knowledge and sharing perspective, we keep tabs on our market sensing of what's going on around us, both locally and nationally, the education and training associated with the use of virtual care, and then those analytics and ongoing process improvement. So I mentioned standardization, and this falls right in track with my industrial engineering background. But some of the things that we have standardized as a department within our organization is our virtual care structure and support, our project implementation work plan to make sure that we're taking lessons learned from past programs and implementing them in future programs, virtual care request forms to make sure that we are collecting all the pertinent information that we need to be able to have a successful program, including a turnkey standard equipment kit and virtual care procedure guidelines, including documentation, external consultation considerations, and then provider work off-site policy and guidelines. We have our EMR integration, which includes the scheduling and registration, coding and billing, patient portal and medical record, the training documents that we use being standardized, the support services in alignment with our IT help desk internally, and our our patient 800 number for support as well, and then standard virtual care metrics and vendor review process. I mentioned earlier how communication was such a key factor in us being able to implement and deploy. So I listed a couple things here that we've really tried to make sure that we are refining this, and this is an ever-evolving process. But from a clinical awareness perspective, we do have an intranet inside our organization that shares a lot of key and pertinent virtual care information. We have chairside handouts and trainings, including tip sheets and reminder emails and test connections that we do for our clinical stakeholders. We did develop e-learning modules on our online university, so providers can go back to those on a regular basis if they need a personal refresher on the capability. And we also developed provider testimonial videos so that we could have peer-to-peer talking about their use and the ease of use for virtual care within their practice. From a patient perspective, we are refining our external web page so that they can better define the various capabilities that we have for our patients. We developed a couple YouTube videos. The one that you saw earlier is an example. And one of the YouTube videos is actually a patient orientation that walks them through how to do a MyChart video visit. And that link to that video is sent to patients as a text reminder for their upcoming MyChart video visit about 3 days before their visit to help be another avenue of communication and reminder. We've also created orientation cards and packets for patients. We did a patient testimonial video, which you saw there, and we have a couple other ones based on some of our specialty use cases as well. And then we had some on-site support in the waiting rooms. And we've recently developed a patient and family advisory council to make sure that we are getting the voice of the customer and really embedding that within our development of programs moving forward. I mentioned earlier that we did a virtual care workshop around our asynchronous functionalities. So we had each of our medical group departments send both administrative and clinical champions to this workshop where they were to create a standard of care that would include asynchronous virtual visits within their practice. And some of the benefits that we made sure we resonated with them was that there was no scheduling constraints, it was less burdensome from the technical requirement, there was low connection and equipment costs, the information was stored within the electronic medical record, and we could really have a robust clinical practice efficiency boost by using some of these tools. So based on the workshop, which had 120 attendees from our various clinical specialties across the medical group, 32 specialties were represented. We had 35 asynchronous projects that stemmed from the workshop, and we did a satisfaction survey after the workshop, and 98% of respondents said that it was an effective use of their time. 100% of them said that the presentation and information was useful and that they were committed to sharing moving forward. And in the bottom, you see some of the anecdotal feedback that we received, that they thought it was one of the most effective workshops that they had gone to. It would be useful for their specific department and the information that they took back. And what was key is we kept the energy high and not only informational, but also they left with something that they could take back to their department and implement and share. Some of the strategies to operation lessons learned that I wanted to share included setting expectations, making sure that we level set the understanding of what virtual care is before we even start, so that there can be a level set expectation of what we're going to do with it within their clinical operations. Really making sure that we have buy-in, and that includes executive leadership, which we've been very lucky here at Henry Ford to have executive buy-in and sponsorship of what we're doing here in the virtual care world. But also once we engage with the department, making sure that we have the right provider champion, support staff, as well as administrator engaged to really bring this to a successful operational input into their clinical practice. Making sure that we had our dedicated subject matter experts or resources within virtual care was very helpful, because this gave us an opportunity to help with lessons learned, networking, and coordination and collaboration, so that we weren't recreating the wheel every time, and these clinical areas didn't feel like they had to dig into the government regulations and everything associated with virtual care to be successful. We have a central area that does that for them. They just have to figure out how to plug it into their practice. Really making sure that we give it time, allow adequate pilot time, but then also having that deadline of where we're going to spread and scale this throughout their department. And making sure that we're chasing satisfaction and really honoring that voice of the customer and not assuming what the customer wants, but really asking what the customer wants. And that includes both internal and external customers. And then making sure that we're promoting Henry Ford Health System providers, that continuity of care, as well as that quality and reputation that those providers can give both virtually and in person. Some additional lessons learned for implementation, creating those standardizations around checklists, work plans, and really working to that process has allowed us to have some reputation positive within our organization and make sure that we are leveraging that expertise. And really making sure that we're assigning roles and responsibilities both within our department and amongst our champions in the department. Keeping it simple and as close to their current clinical workflow as possible, starting small, getting those quick wins, and then scaling it out. And then making sure that it's not only a positive experience, but that the technology is working for both our patients and providers on a reliable basis. Some of the challenges that we've run into, provider and care team adoption, incentive, and change management. It is very much a change management project going through one of these with any area, and really integrating this with our non-employed and affiliate practices who may not be using Epic and MyChart, which is the foundation of a lot of our capabilities. That patient and adoption and customer experience is always a constant challenge, making sure that we have awareness and confidence that virtual care is good medicine for our patients, and keeping digital top of mind where our patients won't revert back to the legacy or historical ways that they've had care delivered and forget that virtual may be a more opportune option. The state regulations and national regulations, keeping up on those is a challenge, as well as reimbursement and that insurance coverage. Although Michigan is a parity state, there is still a lot of inconsistency with our payers, especially in the requirements for their claims, as well as getting to that benefit level coverage or verification, not just for the medical service, but for it being delivered through telehealth as well. And then finally, the technology itself, the reliability, the scalability of the technology, as well as developing a 24/7 support model that will support both our providers as well as our patients if they have technical difficulties during their visit. And finally, I just wanted to hit on the reimbursement one more time. A great quote that I had from one of my leaders is, the purpose of virtual care is to expand the delivery of healthcare services, not to increase our returns. And really making sure that we keep that top of mind. And with Michigan's telehealth parity law, we still are finding a lot of inconsistency with our payers, and a lot of our self-funded plans have written interesting interpretations into their benefits, which has caused us some heartburn. And even with our next generation ACO telehealth waiver, which allows us to waive the originating site and geographic restriction of Medicare, it only does that for a small group of beneficiaries within our accountable care organization. And really making sure that we partner and approach our insurance payers to make sure that we are advocating for virtual care with a partnership between them. So with that, I will wrap up my presentation. That virtual care really enables us to offer better access to healthcare, meet that patient's experience for expectations for online service, reduce costs for time, travel, and convenience, increasing our clinician efficiency, and really making market differentiation, connecting our customers where, when, and how they want to be reached most. Here I have my contact information and our external webpage. And with this, Becky, I can go ahead and open it up for any questions.
Thank you so much, Courtney. Well, look, I'm sure that there's going to be lots of questions. I have written almost a page full of questions for you. So as we're waiting, and again, a reminder, you can access the Q&A portion and write in your questions if you hover your mouse over the bottom of the video screen. So my first question for you is, when did you guys move from, and you mentioned, well, let's start with remote patient monitoring, because you mentioned that was one of the very first telehealth-like programs. When, with that program, who purchases the equipment, and does it get billed to insurance?
So specifically talking about remote patient monitoring, so this has been a program where we are eating the cost for the equipment because we're using it with the value of reduced readmissions and that continuity of care for the patient. So usually this is aligned with an order from a discharging physician because the patient is going into home nursing as well. And so we are purchasing the equipment. We actually have techs that deliver it out into the home and help the patients know how to use it. And they are also deployed to collect the hardware as well once the engagement with the remote patient monitoring is over. And we are just now starting to get into the insurance billing associated with remote patient monitoring because it just wasn't there earlier, but in recent years, that door has started to open. So our e-home care team is starting to look at which insurances are covering and which portions they can do it for. But also, even beyond the order, so maybe a discharging doc may have it for 60 or 90 days, the patient or their caregivers can opt to keep the service for a longer time, but then it becomes a monthly charge to them for basically the renting of the equipment if they want to continue that care.
Some questions, I got a couple of questions that have popped up. First one, what software or company do you use for virtual care?
Yep. So as I mentioned, a lot of our functionality is rooted in Epic. So all of our asynchronous capabilities, which includes e-visits, e-consults, and virtual post-ops, are all built straight into Epic. For our video functionality, we use Vidyo, V-I-D-Y-O, as our video platform, but we are currently deeply integrated into Epic. We right now are on-premise with the servers, but we're actually transitioning to Vidyo Cloud early next year. And we are also looking to transition to context-aware linking instead of deep integration with Vidyo in Epic in 2020 as well. For our clinic-to-clinic functionality, all of our scheduling, documentation, and billing is done in Epic, but our video connection actually resides outside of Epic for that clinic-to-clinic connection. We are currently using Skype for Business. We have on-premise servers for our Skype for Business capability, and it's all within our encrypted and secure portals that we are using that Skype for Business currently for our clinic-to-clinic.
Great. Okay, now I had a question about where to review the presentation and share it with others. What we'll do is for people that have registered for today's webinar, once we get it posted onto our YouTube page, our Upper Midwest Telehealth Resource Center YouTube page, we'll send out a note that it's out there, and then you can share it throughout your organization. Are you able to sign patients up for MyChart if not presenting in person for both peds and adult?
Yep. So we are actively working with Epic right now. So we do have online request forms for patients to sign up or request a MyChart account. They do have to be an existing patient within Epic, so they have to have an MRN. And we have a MyChart advocate team within our contact center that helps facilitate the creation of those accounts if they're physically not at a clinic at the time that they're making that request. And in early 2020, we will also be working on auto instant activation for MyChart, which may allow some events or requests from the patient to, as long as it aligns with an existing MRN within the organization, that it will email to their approved email address a link for them to be able to create a MyChart account.
All right. I want to go back to the organization and how you had a great timeline, but when, I'm imagining, so maybe this isn't true, I'm imagining that cardiology started doing its little thing and pediatrics started doing its little thing. What was the evolution of the current structure that you have for virtual health?
Yeah, so when I actually came into the telehealth world of Henry Ford around 2005. And at the time, 2015. At the time, primary care was also already very active in the asynchronous space, but not the video space. And we had dermatology who was just starting to think about some of this video capability. So I would say those are probably the two specialties where it kind of started. And so from there, that's when me stepping into my role, we really looked outside of who the clinical user was and took a step back to develop that wheel of capabilities that we talked about, and really making sure that we created standard processes so that no matter who the user was, as long as we could sit down and make sure that the use case was appropriate, we could find the right capability to fit their needs. And so from there, that's really where behavioral started taking off, dermatology started expanding their usage, and then primary care started getting into the video realm as well. Early on, we used a lot of our what I'll call cheerleaders and kind of earlier adopters to really stretch our legs and test our processes to make sure that everything was working. And what was nice about some of those early adopters is we could also use them as champions and peer-to-peer testimonials as to how this had really worked and helped their practice. And we really leveraged them then when we started doing a lot of road shows and really getting ourselves out in front of our clinical champions and leaders of the organization to say, hey, we could do this, you could do this, here's somebody or your peer that has done it and how it's worked, work with virtual care. And so for a while, it was a lot of pounding the pavement and really getting it out there that virtual care was available and who to work with to do it. And actually now we have a work queue of projects that have been requested that are waiting for us to be able to free up some time to work with them. So the tables have kind of shifted over the last 4 years or so of us trying to plead people to do it to people coming knocking on our doors looking for it.
Right, absolutely. Can you describe, you talked about doing pilots with a small scope. Can you describe one of your pilots and how that came about?
Yeah. So we had one of our inflammatory bowel disease specialists. So she has a very specific subspecialty within gastroenterology. And she had heard that virtual care was an option and wanted to try it out for her patients because she thought the value would be great. So we worked with her and one of her practices to set up a pilot with her being able to do distant consultations with patients at a more convenient location. So we partnered with another facility that would host the patient, and we worked with her to get her set up to be able to do these visits and really tried it for a couple months to make sure that it worked for her patients, to make sure that it fit into her schedule, and kind of work out some of the coordination, workflow, and other type of components of being able to deliver care that way. And then after a couple months, and they really felt comfortable with it, and especially she was able to show some of the value and the ROI of this mini pilot that she was doing, we were able then to approach the rest of her department to talk about expanding that functionality to additional providers within her subspecialty, but then also to additional sites and locations as well. School-based health is another good example where we started with one school with a TIDO device connecting to pediatricians, and now they have expanded to about another 10 schools because they've been able to kind of do small tests of change with that technology and with that workflow, and with that working, have the confidence to be able to roll that out to additional sites.
Why did you choose to use TIDO when you have such a large Epic shop?
Yeah, so TIDO gave us the ability to have that exam-enabled video visits. So one of the things that we realized when we started doing our MyChart video visits, which is truly just audio and video, is a lot of the specialty providers, they wanted to be able to hear the lung sound. They wanted to be able to look in the ear. And so the scope of medical conditions that they could service using that straight audio video capability was very limited. But if they could get just a little bit more of those examination factors in real time, they could give more, offer more clinical services and kind of offer a wider band of services. So those are the specific use cases where we usually look to plug in TIDO Care as the connection capability, is when the added value of having those peripherals and those vitals in real time for that clinician add to the scope of practice that they're able to execute.
Yep, cool. And then we're almost out of time. We've got, here's another question about TIDO. Is TIDO launched within Epic for your providers?
So not yet. I mentioned that in 2020, we are looking to go to context-aware linking within Epic instead of deep integration. With that transition from strictly just video with deep integration to context-aware linking, that will also open the door for us to be able to plug in some of our other video platforms, which includes TIDO.
Mm-hmm. Thank you. And then one final question. Michigan, for the different states that I've heard and work with, has seemed to have the largest preponderance of self-insured programs where that they don't follow that parity law. Have you guys looked, I mean, is it, what kind of employer groups are doing these self-funded plans?
The autos. It's Michigan, right? So a lot of the automotive and actually a lot of the school districts are transitioning to self-funded plans. So GM, Ford, a lot of them, they've done self-funded plans, and a lot of our school districts throughout Michigan, they found it more fiscally appealing to do a self-funded plan underwritten by an insurer, which then gives them the opportunity to build their own benefit level. Now, a lot of them have kind of followed the trend and had an open door to telehealth, which is very good. But some of them have been misled that telehealth is a product versus a service. And what I mean by that is some of the vendors have gotten in front of them and said, well, you should put telehealth into your benefits, but make sure that you write that it's only can be delivered from American Well, Teladoc, MD Live. I mean, I could rattle off. And so those self-insured plans, not knowing any different, have written into their benefits, yes, we cover telehealth, but only via this vendor as a product, where really what they should have written it in as is a service, because here that patient's own primary care physician is trying to deliver care via telehealth, and they are not able to get reimbursed because of the way they've written these benefit levels. So when we've come across that with some of our payers or our employers, we're trying to advocate, but it's been very difficult, and I think it's just lack of knowledge. And so we've been trying our best to get in front of some of those self-funded plans and insurers to clarify so that they can better serve their beneficiaries.
Mm-hmm. Well, thank you again very much, Courtney. I appreciate you presenting for us today, and I want to wish everyone happy holidays and a happy new year. Thanks so much.
Thank you.